Hi guys. So in today's lecture we will discuss heart blocks, also known as atrioventricular blocks or AV blocks. And for a moment, just imagine heart block as heartbreak. Both has HBs, and in both cases you can have misbeats. Now just imagine heartbreak as a heart with arrow inside, and this arrow is striking exactly at the AV node, resulting into delay of conduction from SA node to the ventricles, and it can also result into missed beats. And in rare occasions, it can also result into complete damage of AV node, resulting into complete dissociation of atria from ventricles, resulting into third degree or complete heart block. So let's discuss. Right. So in discussion on heart blocks, that is atrioventricular blocks, that is AV blocks, let's focus on this AV node somewhere in the center. This can be your SA node. Okay. Now you can also appreciate this arrow. This arrow can cause significant damage to this AV node, resulting into decreased speed of conduction across this AV node. And this can result into delay of impulse conduction from SA node across AV node to the ventricles. And this will lead to increased PR interval in particular. This can be hallmark of heart blocks. We will discuss PR intervals in detail. So initially there will be only delay in conduction, but each and every impulse will pass across this AV node. But over period of time, there can be blockage of few impulses across this AV node and resulting into missed beats. Okay. Now, over period of time, there can be further damage of this AV node, and now this AV node will block each and every impulse arising from SA node. Or in other words, this AV node will not be able to pass any of the impulses arising from the SA node going across the AV node to the ventricles, and this will lead to third degree heart block. Now, atria will contract from the impulses via SA node because SA node is present in atria, whereas ventricles will develop some ectopic focus or some ectopic pacemaker, and they will contract at their own rate. So there will be complete AV dissociation, that is atrioventricular dissociation in case of third degree heart block, which can be fatal as well. Let's proceed. Here in this first diagram, you can appreciate normal AV node. And this normal AV node will normally conduct impulses from SA node to the ventricles across the conducting system. Whereas in second case, I am trying to appreciate that there is AV node which is malfunctioning. And due to malfunctioning of this AV node, there will be some difficulty in passage of impulses across this AV node, which can result into increased PR interval, and it can also result into misbeat, and it can also result into complete heart block. We will discuss. So this AV node is center of attraction in this lecture, okay, and particularly resulting into increased PR interval. But it is not absolutely mandatory to have increased PR interval in case of heart blocks. We will discuss over a period of time. Now let's draw four-chambered heart along with conducting system. These are your atria, and then you have ventricles. Let's also label it. This is your right atrium, this is your left atrium, this is your right ventricle, and this is your left ventricle. Now also draw the pacemaker and conducting system of heart. This has to be your SA node in the right atrium, and this SA node is your pacemaker. Now also draw the center of attraction of this lecture, that is your AV node. Now you can very well appreciate that if impulses has to reach to the ventricles, they have to cross this AV node, and in normal conditions as well, that is in physiological situations, this AV node causes some physiological delay of impulse conduction, and this is known as physiological AV nodal delay. This delay is physiological, and this delay allows atria to contract first followed by ventricles. Okay, so there is some physiological delay because this AV node is very slow conductor of these impulses. So this AV node will result into physiological AV nodal delay. Therefore, atria will contract first, okay, followed by ventricles. Now let's also draw the complete conducting system. Then you have bundle of His. After bundle of His, you have right bundle branch leading to Purkinje fibers. This is your right bundle branch. And on the left side, towards the left ventricle, you have left bundle branch. And ultimately, you have Purkinje fibers supplying impulses directly to the left ventricle wall. This is your bundle office. So, in case of heart blocks, this physiological AV delay further increases. resulting into delay of conduction more than physiological limits. And this particular thing is known as heart block. Try to understand. See, impulses arise from SA node and they ultimately reach to the ventricles, but after passing this AV node, okay, and this time SA node to ventricles, this time taken by impulse conduction is known as PR interval. Now, try to understand, in case of any malfunction of AV node, either these impulses will not cross this AV node or these impulses will cross this AV node but with some delay. So, this PR interval can be increased in case of heart blocks. Okay, try to understand this particular thing, that it is not always the AV node. Sometimes the adjacent structures can also be involved in case of heart blocks. Okay, let's now see pacemaker and conducting system of heart. This is your SA node, that is pacemaker, situated in the right atrium. And then you have conducting system to conduct these impulses arising from SA node to the ventricles. And in conducting system, you have AV node, bundle office, bundle branches. And then Purkinje fibers finally take these impulses towards the ventricles. Let's redraw it. You have SA node, that is pacemaker, and then you have AV node. You guys already know that this AV node is situated at the atrioventricular junction. Anything beyond this AV node will fall into ventricles. Let's now draw bundle office. So these impulses reach bundle office, and later to bundle office, these impulses divide into two parts. That is left bundle branches taking these impulses via Purkinje fibers towards the left ventricle, and then you have right bundle branches taking these impulses via these Purkinje fibers towards this right ventricle. Now try to appreciate few things. See, anything beyond this AV node, right, will fall into ventricles, no doubt. And what is PR interval? PR interval is time taken by the impulses from SA node to reach to the ventricles. So this should be your PR interval. And PR interval is mostly increased or prolonged in cases of heart blocks because functioning of AV node in particular is affected. So this AV node is your center of attraction, but in case of heart blocks, problem mainly occurs at AV nodes and it can also occur at adjacent areas. So damage to these areas can result into heart block. Now you can appreciate that heart block can occur due to problem with AV node, due to problem with internodal fibers, or due to problem in bundle of His. But if the problem will occur at bundle of His, it will not result into increase in PR interval. This has to be noted. So there can be multiple types of heart block depending on the area of blockage and depending on the severity of blockage. Okay. Now let's appreciate few more things. You have left bundle branch and you have right bundle branch. Any problem happening at these branches will result into bundle branch blocks, and we will discuss bundle branch blocks in next lecture. Now again focus on AV nodal blocks or heart blocks. So there can be multiple types of heart blocks classified as first degree, second degree, third degree. And this second degree is further classified into Mobitz type 1 and Mobitz type 2. And by this diagram, you can appreciate that PR interval will be mostly increased in cases of heart blocks, but it will stay constant when there will be problem with bundle office, that will be Mobitz type 2 heart block. Okay, see, you have pacemaker in form of SA node present in the wall of right atrium. And what is firing rate of this SA node? This is in range of 60 to 100. Now try to appreciate few things. Any structure present in this conducting system can act as pacemaker in case your SA node is non-functional. See, firing capacity of SA node is 60 to 100, whereas firing capacity of AV node or bundle office can be in range of 40 to 60. Firing capacity of bundle office or Purkinje fiber can be in range of 30 to 40. So you can appreciate that firing capacity of SA node is maximum. So SA node acts like boss. It will inhibit automaticity arising from any other structure in the conducting system. But in case your SA node is deceased, take example of sick sinus syndrome. In case of non-functional SA node, any structure below this SA node can take up activity of pacemaker. Okay, try to understand few things. See, this is your four-chambered heart. You have atria above and then you have ventricles. Try to appreciate few things. You have SA node over here. This SA node supplies impulses to the atria as well as to the ventricles via the conducting system. And after SA node, you have AV node. Suppose your SA node is non-functional. Take example of sick sinus syndrome. Then this pacemaker activity will be taken up by the AV node. But heart rate, if this AV node acts as pacemaker, will be maximum of 60. Whereas structures below, this AV node can also act as pacemaker in case your AV node is non-functional. Suppose your bundle office takes up your pacemaker activity. Heart rate will be again in range of 40 to 60 at max. And suppose your bundle office is damaged. Okay, take example of Mobitz type 2 heart block we will discuss. Then automaticity will be taken up by bundle branches or Purkinje fibers. And you can very well appreciate that if these structures will act as pacemaker, heart rate will be significantly lower. So in case of heart blocks, particularly these impulses from SA node might not reach ventricles. So heart rate will be significantly lower because other structures cannot fire at the same rate as your SA node was doing. Okay, now let's proceed. Now let's focus on most important parameter in relation to AV blocks, that is your PR interval. What is PR interval? This is time taken by the impulse to reach to the ventricles from SA node. Let's redraw it. You have P wave followed by QRS complex, and then you have finally T waves. And this PR interval starts from P wave to the starting of Q wave, and sometimes Q wave can be absent, so that you can take a starting of R wave. So this particular time period is your PR interval. And what is normal PR interval? This is approximately 3 millimeter, that is 3 small squares in ECG to 5 small squares in ECG. And this 5 millimeter will be equivalent to 1 large square. So anything more than one large square in relation to your PR interval will be considered as prolonged PR interval. This 1 millimeter is equal to 1 millimeter is equal to 0.04 seconds. So in terms of seconds, your PR interval should be 0.12 second to 0.20 second. Now this is pretty much clear. What is prolonged PR interval? Prolonged PR interval prolonged is equal to greater than 0.20 seconds, is equal to greater than 5 millimeter, is equal to greater than 1 large square. So in discussion on heart block, our PR interval will hold lot of importance. In majority of cases, this PR interval will be increased. Okay, let's recap a bit. So this is your SA node, that is pacemaker, along with conducting system, which includes AV node, bundle office. Right. Any problem at these level will represent your AV nodal blocks, particularly at the AV node. And any problem at level of bundle branches will represent bundle branch block. We will discuss bundle branch block in next lecture. Okay. So in AV blocks, particularly you will deal with increased PR interval, but not always. Try to appreciate one point. See, what is PR interval? This is time taken by the impulse to reach to the ventricles, but this bundle of his is already in ventricles. Sometimes this AV block might be due to blockage at the level of bundle of his, particularly in Mobitz type 2 heart block. In those cases, PR interval will be normal, but it will be accompanied by misbeats. We will discuss in over period of time. This particular interval is your PR interval, and it will be mostly increased in cases of heart blocks, but not always. Try to remember this point. Now let's also calculate PR interval. This is the starting of P wave, and here you can appreciate starting of Q wave. So this is your PR interval. And what is normal PR interval? This is 3 mm to 5 mm, and in this case your PR interval comes out to be approximately 4 millimeter, and this will be equivalent to 4 into 0.04. This will be 0.16 second. What is range? 0.12 to 0.20 second, and this lies in normal range. So this is your normal PR interval. In case of heart blocks, there will be prolongation of PR intervals in form of more than 0.20 seconds, in form of more than 5 millimeter, or in form of one large squares. Okay, so this is basic understanding in context of PR interval and heart block. Let's proceed further. Here, what is normal range of PR interval? 0.12 to 0.20 second. Again, let's recap. This is equivalent to 3 mm to 5 mm. Anything more than 5 small squares will be considered abnormal, will be considered as increased PR interval, and then heart blocks would be evaluated. Now let's upgrade our knowledge. This particular time interval is your PR interval, and in this case as well you can count it is equivalent to 4 millimeter. In the similar way you have QT interval starting from Q wave to the end of T wave. This is your QT interval. And now develop a logic. PR interval will be considered prolonged if it is more than 5 millimeter. What about QT interval? See, QT interval is approximately 9 millimeter, that is 9 small squares to 11 small squares. Okay, on an average it will come out to be 10 small squares or 2 large squares. So QT interval will be considered prolonged if QT interval is more than 10 millimeter. Right? If QT interval will be prolonged, we will discuss in upcoming lectures about torsade de pointes, that is polymorphic ventricular tachycardia, okay, a life-threatening arrhythmia. So in case of PR interval prolongation, we will deal with heart block. Whereas in case of QT interval prolongation, we will discuss a life-threatening arrhythmia by the name of torsade de pointes, okay. So this is for general understanding about PR interval and QT interval. After discussing basics of pacemaker and conducting system of heart, after discussing PR interval and prolonged PR interval, now let's discuss types of heart blocks known as degrees of heart blocks. You have first degree, you have second degree, and you have third degree. So let's write it down: first degree heart block, second degree heart block, and third degree heart block. Third degree heart block is also known as complete heart block. In case of third degree heart block, AV node will not allow any of the impulses from SA node to pass via AV node to the ventricles. Whereas in case of first degree heart block, AV node will allow each and every impulse from SA node to the ventricles, but after a significant delay represented by increased or prolonged PR interval. But atria and ventricle will contract and relax at the same rate. So atrial rate will be equal to ventricular rate, and therefore you can appreciate that there will be no missed beats. We will discuss no missed beats. Whereas in case of second degree heart blocks, there will be malfunction of either AV node or bundle of his, resulting into missed beats. So this second degree heart block can be of two types. One is Mobitz type 1 and second one is Mobitz type 2. This type 1 rhymes like 1. Therefore, this will be also known as Wenke-Bach phenomena. Wenke-Bach phenomena. In case of Wenke-Bach phenomena, there will be problem with AV node resulting into increased PR intervals, and later on you can find missed beats as well. Okay, that is atrial rate will be more than ventricular rate. Whereas in case of Mobitz type 2, there is mainly problem with bundle of his, and this will result into missed beats, but PR intervals will stay normal. Right? This has to be noted because bundle office is part of ventricle, and in case of PR interval, we discussed that this is time taken by the impulse to reach from SA node to the ventricles via AV node. Bundle office is already in the ventricle. Okay, so in case of problem with bundle office that is related to Mobitz type 2 block, there will be normal PR interval. Okay, so this is basic understanding of what types or degrees of heart blocks. So you have 3 degrees of heart blocks, and as of now you can understand that in case of heart blocks, main problem will happen at AV node. But sometimes problem can also exist around AV node, that is at the level of bundle office or at the level of internodal fibers as well. Okay. Now let's discuss first degree AV block, also known as first degree heart block. In case of first degree heart block, there will be problem with the AV node resulting into significant delay of passage of impulses via this diseased AV node. But each and every impulse will be able to pass via this AV node, but after a significant delay. Okay. So in this case, impulses will arise from SA node, they will pass via AV node, and they are going to reach ventricles, but after significant delay because there is diseased AV node. So this is your first degree heart block. In case of first degree heart block, there will be prolongation of PR intervals. That is, PR interval will be more than 0.20 second, will be more than 5 millimeters, or will be more than one large square. But ultimately, each and every impulse arising from SA node is going to reach the ventricles, right? SA node already has provided impulses to the atria. So atrial rate and ventricular rate will be equal and there will be no missed beats. So in case of first degree heart block, there will be increased PR interval, but atrial rate will be equal to ventricular rate. There will be no missed beats. Let's also draw an ECG. Okay, this is your P wave, this is QRS complex, next P, next QRS, next P, next QRS. Now also appreciate the PR interval. This is your PR interval, this is PR interval, this is PR interval. Just assume in case of normal sinus rhythm, your PR interval is between 3 millimeters to 5 millimeters, that is below 0.20 seconds. Whereas in case of first degree heart block, there will be prolongation of PR interval. Also appreciate even now each and every P wave is accompanied by QRS complex. Okay, so there will be no missed beats. Number of P waves will be equal to number of QRS complexes. So in case of first degree heart block, there will be prolongation of PR intervals and it will be more than 5 millimeters. It will be more than 0.20 seconds. But number of P will be equal to number of QRS complexes, that is atrial rate will be equal to ventricular rate. There will be no missed beats. Whereas in case of second degree heart block, there can be PR prolongation, but hallmark of second degree heart block is presence of missed beats. We will discuss. Let's see. In case of first degree heart block, there will be merely prolongation of PR interval more than 0.20 seconds, more than one large square, more than 5 millimeters. Okay, so there will be prolongation of PR intervals, but each and every P wave will be accompanied by QRS complexes. I mean to say that atrial rate and ventricular rate will be normal. There will be no missing of ventricular beat, that is, there is no incidence of missed beats. Okay. Now let's discuss second degree AV blocks, that is also known as second degree heart block. And hallmark of second degree heart block will be presence of missed beats. And therefore atrial rate and ventricular rate will not be equal. Atrial rate will be more than ventricular rate. Okay, let's try to understand. In case of second degree heart block, you can have two types. You can have Mobitz type 1 or you can have Mobitz type 2 heart blocks. Okay. Now this Mobitz type 1 rhymes like Venki back, one Venki back. So this is also known as Venki back phenomena. In case of Mobitz type 1, there will be problem with AV node and therefore conduction will be slow. It will result into progressive prolongation of PR intervals and ultimately there will be missed beat. We will discuss. Whereas in case of Mobitz type 2, there will be problem in bundle of His and therefore PR interval will be normal. But over period of time, you can find some missed beats that is characteristic of what type 2 heart block or second degree heart block. So this is very important. In case of Mobitz type 1, there will be problem with AV node resulting into progressive prolongation of PR intervals until one beat is missed. Whereas in case of Mobitz type 2, there will be problem with bundle office and therefore PR interval will stay constant, but you can appreciate missed beats here and there. So both are cases of second degree heart blocks, but pathology is different. In Mobitz type 1, there will be problem with AV node. There will be problem with PR interval, whereas in case of bundle office, PR interval will be normal, and here and there, due to malfunctioning of bundle office, there will be no conduction across this bundle office, resulting into missed beats. Try to understand. This is your first degree heart block, and this is reflected by increased PR intervals, and number of P waves are equal to number of QRS complexes. So in case of first degree heart blocks, there is merely prolonged PR intervals and there are no missed beats, and therefore number of P waves is equal to number of QRS complexes. Whereas in case of second degree heart blocks, there are missed beats. You can appreciate one missed beat over here and you can appreciate one missed beat over here. So in case of second degree heart block, it can be Mobitz type 1. In Mobitz type 1, PR interval will keep on progressively increasing and there will be presence of missed beats. Missed beats means there will be P wave without any QRS complexes. Whereas in second degree heart block, which is Mobitz type 2, there will be normal PR interval, but here and there will be presence of missed beats. Okay, so both are different. Whereas in case of third degree heart block, we will discuss there will be complete malfunction of AV node resulting into complete atria and ventricle dissociation. Okay, now let's try to appreciate this thing. In Mobitz type 1, there will be problem with AV nodes and it will result into progressive prolongation of PR intervals until one beat is missed. Okay, so in case of Mobitz type 1, there will be prolongation of PR interval because we are dealing with problem with AV nodes. So there will be progressive, this word is very important, there will be progressive prolongation of PR intervals, and then it can be followed by missed beat. That is, there will be P wave, but it will be not accompanied by QRS complex. Okay, so atrial rate will be more as compared to ventricular rate. Let's draw it. So you have P wave followed by QRS complex, and then you have T wave. Again, you have P wave followed by QRS complex, and then you have T wave. Then you have next P wave followed by QRS complex, and then you have T wave. But next P wave is not accompanied by QRS complex. Let's try to appreciate it. This is your P wave, this is your QRS complex, this is your T wave, this is your next P wave, and this is second QRS complex. This is your third P wave, and this is your third QRS complex. Okay, and this is your P4, but here you have no QRS complex and it is again followed by next P wave. So this is P5. QRS is missing. So this is your misbeat. Here you can appreciate that there is progressive PR interval prolongation. See, in this case, this is your PR interval. In this case, this is your PR interval. In this case, this is your PR interval. And then later to this, you have misbeat. So there is progressive prolongation of PR intervals followed by presence of misbeats. In this case, you can appreciate 1, 2, 3, 4. There are 4 P waves, but there are only 3 QRS complexes, 1, 2, and 3. So there will be only 3 QRS complexes. So this is also known as 4:3 second degree heart block of Mobitz type 1. Okay. So there will be progressive prolongation of PR intervals until one beat is missed, and then again there will be progressive prolongation and again one beat will be missed. So this is your Mobitz type 1 heart block. And now let's discuss Mobitz type 2 second degree heart block. Too simple to understand. Mobitz type 2 second degree heart block. We have already discussed that in Mobitz type 2 there will be problem with bundle of his, and therefore there will be no prolongation of PR intervals. But due to problem with bundle of his, because we are dealing with second degree heart blocks, there can be complete obstruction to some of the impulses resulting into formation of missed beats. So here PR interval will be normal and each and every PR interval will be equal, but there will be presence of missed beats here and there or at regular intervals. Let's try to understand. In case of second degree Mobitz type 2, there will be normal PR interval. Okay, so this is your P1, this is your QRS1, and this is your T1, and it will be followed by next P wave and next QRS complex and next T wave. Then again you have P wave followed by QRS complex and again next T wave. But after a while there can be P wave not followed by next QRS complex. So there is again presence of missed beat. This is important. PR intervals are normal and equal. Let's try to appreciate these. These are PR intervals and each and every PR interval is normal and equal, but it is followed by misbeats. Sometimes due to problem with bundle office, there can be complete obstruction to few of the impulses resulting into formation of misbeats. Therefore, atrial rate will be more as compared to ventricular rate. And during the time of misbeat, patient can appreciate presence of dizziness or vertigo or sometimes even syncope. Okay, so this is your Mobitz type 2 second degree heart block. Now try to recap. In case of Mobitz type 1 second degree heart block, problem will be with AV nodes, and this will result into progressive PR intervals prolongation followed by missed beats. Whereas in case of Mobitz type 2, there will be problem with bundle of his, and therefore there will be normal PR intervals but there will be presence of missed beats. Too simple to understand. So this is basic difference between Mobitz type 1 and Mobitz type 2. Okay, in both these cases, atrial rate will be more as compared to ventricular rate due to presence of missed beat. This is again very important. Okay, because there is presence of missed beats. Okay, and now there is little twist. See, take example of Mobitz type 2. In case of Mobitz type 2, there will be normal and equal PR intervals followed by missed beats. Whereas in case of Mobitz type 1, there will be progressive prolongation of PR intervals and it can be followed by missed beat. See, now try to understand. In case of Mobitz type 2, there will be normal PR intervals, but sometimes you can appreciate presence of missed beats. That is P wave not followed by QRS complex, instead P wave again followed by next P wave. So there can be presence of missed beats. Now try to appreciate this particular thing. In case of Mobitz type 2, PR intervals will be normal and each and every PR interval will be equal to each other. Okay, and it can be followed by missed beats. Now try to appreciate. PR interval 1 is equal to PR interval 2 and PR interval 2 is equal to PR interval 3. Each and every PR interval is normal and equal. Whereas in case of Mobitz type 1, there will be progressive prolongation of PR intervals. Let's try to appreciate this particular thing. This is PR interval 1 and this is lesser than PR interval 2 and PR interval 2 is lesser than PR interval 3. So here you can appreciate that progressive prolongation of PR intervals and then you can appreciate presence of missed beats. Now, you can classify a particular case as a case of Mobitz type 1 or Mobitz type 2 if you have more than one PR intervals. But sometimes there can be no second PR interval to compare with. So you cannot label it as a case of Mobitz type 1 or Mobitz type 2. Instead, you can classify that thing as 2:1 AV blocks. Let's try to understand. Let's draw an ECG. Suppose this is your P wave followed by QRS complex and T wave. Then you can have next P wave not followed by QRS complex, again P wave, again QRS complex and again T wave. Then again you have P wave followed by next P wave, no QRS complex. So here you can appreciate one thing. This is your P1, this is your QRS1 and this is your P2, this is your P3 and this is your QRS2. Then again you have P4 and there is again P5. Now you can appreciate few things. This P wave is conducted but this P wave is not conducted, right? That is there is presence of missed beat. Again this P wave is conducted but the next P wave is not conducted, again you have missed beat. So there is alternate conduction and no conduction. There is no next PR interval to compare with. This is your PR interval and then there is missed beat. Then again you have PR interval, again you have missed beat. So you don't have the second PR interval to compare with. So this particular case is known as 2:1 AV block or 2:1 hard block. This is different from Mobitz type 1 or Mobitz type 2 because you don't have the second PR interval to compare with. Okay. So sometimes this is asked in exams as a case of 2:1 hard block or 2:1 AV blocks. I hope you guys got my point. Now let's recap second degree hard block. There can be Mobitz type 1 or Mobitz type 2. In case of Mobitz type 1, there will be progressive prolongation of PR interval and there will be presence of missed beats. Whereas in case of Mobitz type 2, PR intervals will be normal and equal and there will be presence of missed beat which will be hallmark of second degree hard block. So in these two cases, you have to compare PR interval 1 with PR interval 2 with PR interval 3. So in these cases, you need at least more than one PR interval to compare. You need at least more than one PR interval to compare with. But what is happening in case of 2:1 hard block? There is no second PR interval to compare with. See, this is your PR interval and then you have missed beat. Again, you have PR interval, again you have missed beat. Okay. So in this particular case, you have alternating missed beats. Alternate P wave is not conducted and this particular thing is known as 2:1 AV block or 2:1 hard block and this is different from Mobitz type 1 or Mobitz type 2. Let's now discuss third degree hard block. also known as complete heart block. In this case, there will be complete malfunction of AV nodes, and now this AV node will not be able to pass any of the impulses arising from SA node to the ventricles. Let's try to understand. This is your four-chambered heart, and you have AV node over here, and in this case there is complete malfunction of this AV node. So this AV node is not going to allow any of the impulses from SA node to the ventricles. This is your SA node. SA node is present in the atrium. So SA node will anyway will be able to supply impulses to the atria, and rate of this AV node is approximately 60 to 100 per minute. On an average you can take 72 per minute. Whereas now ventricles will contract with help of ectopic pacemaker. This can be in bundle office, this can be in bundle branches or Purkinje fibers. And now maximum rate of ventricles will be around 40 per minute. Therefore, atrial rate will be approximately 72 per minute, whereas ventricle rate will be approximately 40 per minute. So there is lot of discrepancy. Plus these two structures are not contracting with help of same impulse. So there is lot of asynchrony. Now atria is contracting with help of SA node, whereas ventricles are working with help of some ectopic pacemaker arising from bundle office or any of the structures of the conducting system, and ventricular rate will be much lower. Let's try to understand. So in case of third degree heart block or complete heart block, there is no atrial activity conducted to the ventricles. So atria and ventricles are controlled by independent pacemakers. So atria will contract with help of SA nodes, something like this, at regular intervals, approximately at the rate of 72 per minute. But ventricular rate will be lot slower, something like this. This is your QRS complex and this is your QRS complex, and both are independent to each other. Therefore, there will be variable PR intervals, and this is your PP interval, right, known as PP intervals, that will represent atrial rate, and this is your RR interval that will represent your ventricular rate or the heart rate. This RR interval duration will be more as compared to PP intervals because no other pacemaker can have firing activity as fast as SA node. So you have PP intervals like this and you have RR intervals. Okay, PP intervals will be smaller as compared to RR intervals, which will be larger because ventricular rate will be lesser as compared to atrial rate. So there is complete asynchrony between atria and ventricles. Okay, so this is your third degree heart block. Right. After discussing first degree, second degree, and third degree heart block, now let's talk about treatment part. See, first degree heart block is mainly asymptomatic, whereas second degree heart block can be symptomatic or asymptomatic. See, second degree heart block, particularly Mobitz type 1, can be asymptomatic, but Mobitz type 2 is always symptomatic. And plus, there is chances of progression of second degree heart block into third degree heart block, that is complete heart block. So treatment of second degree and third degree heart block should be ideally done with help of pacemaker implantation, right? And in medicinal treatment, you can also use atropine, but definitive treatment has to be done with help of pacemaker implantation. Okay, so that's all about heart blocks. In next lecture, we will discuss bundle branches.